Good evening and hello everybody. My name is Charles Kingsland. I'm the Professor of Reproductive Medicine and also the Group Clinical Director of Care Fertility, and I'm based at the Cares Clinic in Liverpool, although we communicate and connect with all our care family. But I'm going to talk tonight about something that is very dear to my heart, and that is testing infertility. What tests are useful, what tests may be not so useful, but most importantly, what tests may be useful for you. We've had a load of questions, so what I thought I'd do for the first 10 minutes or so is to go through what the basics of what we do in a fertility clinic if you think you've got a fertility problem, and then we'll answer some specific questions. There's been an awful lot of questions tonight, so what I'm going to do is try and get through as many as I can, and those that we can't get through, Chloe will try and get back to you, or I will email you back after the Instagram has finished, or tomorrow morning. So, testing infertility. Now, when I was at medical school, 5 years, I was going to say 5 years ago, but it was a bit longer than that actually. Whenever we're faced with a medical problem and we want to make a diagnosis, there are certain things we have to do. Now, nowadays it's probably a little bit looser than it used to be, but in those days, and certainly in my practice, what you do to make a diagnosis, you take a history, you examine the patient, you do some tests, you make a diagnosis, and based on that diagnosis, you then decide which is the best treatment for that person, the patient, or the couple. And infertility is no different. It's a disease just like any other. And people say to me, well, why is fertility a disease? It's not a significant condition, is it? It's probably part of nature. Well, actually, if you think about what a disease is anything that puts you ill at ease. Dis means abnormality. Ease means easiness. So anything that puts you ill at ease, of which fertility is a classic example, that is classed as a disease, and that warrants investigation and adequate treatment. And any of you that you are suffering from a fertility, you will know that you are ill at ease and you need answers. So what happens? Get a pen and paper just in case, because you'll be able to do this to yourself tonight. You take a history. Now, first and foremost, when you take a history with a couple who are trying, or a single lady that is trying to achieve a pregnancy, you want to know the first crucial question: how old are you? I've said this many times before, and I don't apologize to say it again. Girls lose their fertility quicker than boys. Boys are sperm factories. We have all the ingredients in our bodies to make sperm every day of the week. Some days we're good at it, some days we're bad at it, but we can make sperm up until the day we die. We might have trouble delivering it when we're older, but we can make it. As we get older, the sperm loses its quality, but we can, in theory, reproduce right up until 70s and 80s. In fact, Charlie Chaplin, that famous silent comedian, he had his final child when he was 85 years old. Yeah, I know, amazing, isn't it? Didn't have Sky Sports in those days. And that's unlike girls who are egg warehouses. Women cannot make eggs. They are born with their full complement of eggs, which they lose throughout their lifetime. So when a couple come to see me and they're 35 years old, the male sperm may be 2 weeks old, but I know for a fact that the female's eggs are 35 years old. And that's why a female loses her fertility quicker than a male's, and it goes down very quickly over the age of 30. Now, when a couple think they may have a fertility problem, we normally say 12 to 18 months of trying with normal, regular, unprotected sexual intercourse, most couples will have achieved a pregnancy after 18 months. But the circumstances vary. If you are 40, you might not want to last that long or wait that long to have a diagnosis of infertility. And your anxiety may be such that actually I want to find out more about this difficulty, and I've only been trying for 3 months. That's fine. Similarly, if you're 20, you've got a good ovarian reserve, you've got far more time. But again, if you've been trying for 6-8 months, you might feel anxious. You might see all your friends being pregnant. You might then see everybody pushing a pram, and everybody's, every shop on the high street is Mothercare, and all the the aisles and Asda contain nappies. Those sort of things that start playing on your mind, and you might want to find out. So, age. How long have you been trying? Now, there are other aspects of your history which are important. Your periods. Are they regular? Are they predictable? And are they irregular? Now, the important thing is it's not necessarily how much you bleed, it's when you bleed. If a patient says to me, my periods, Professor Kingsland, occur on the 25th of the month, they're 3 days, they last for 3 days, and they are predictable, then there's an 85% chance that she is releasing an egg, because it's the release of the egg that creates the predictability. Now, if you say, well, my periods occur every Preston Guild, that means your chance of ovulating go down, and some books will say there's only a 15% chance. That doesn't mean to say you haven't got the eggs. It just means to say that you're not releasing them. So the next question that I want to know is, have I been pregnant before? Have you been pregnant before? Generally speaking, if you've been pregnant before, then given a fair wind and not as long as you're not too old, you'll probably get pregnant again. As I'm saying, I'm generalizing, it's different for different people, but that is important. The other important thing is, are you looking after yourself? Do you have a regular smear? That's also significant, because the patient who says to me, actually, I don't have a smear. Well, you think, well, are you looking after yourself as well as you could be? So those are the important things in the history. Then we go to the past medical history. What's happened to you in the past? Have you had miscarriages? If you've had live births, were they uncomplicated? Did you have a lot of time? Did you spend a lot of time trying? Have you got any serious illnesses? Things like rheumatoid arthritis, Crohn's disease. Have you had a past history of cancer? Or have you had a past history of very powerful drugs that may have affected your fertility? Those sort of things. Next thing, what do you do for a living? There are some professions which are associated with a lower fertility generally. Of course, I'm generalizing, than a higher fertility. So, for example, men who work outside with active jobs, who keep their testicles nice and cool, landscape gardeners, postmen, tend to have, as a profession, higher sperm counts. People who are highly stressed, sit on their testicles all day, bus drivers, taxi drivers, they tend to have a lower sperm count. It's how you look after your testicles. Bike riders, if you spend a lot of time in the gym, these are the sort of things that can adversely affect your sperm count. There are some female professions. I remember being a clinical advisor to a transatlantic airline, and there was a high degree amongst the female staff of infertility because they were passing over the date line, and it was playing havoc with their internal regulatory mechanisms, and they weren't ovulating. So there was a higher incidence of fertility. If men work in hot atmospheres, for example, that heat up their testicles, it's not a good thing for your testicular health. Do you smoke? Smoking, for those of you who've listened to me before, smoking is bad for you. It's bad for your health. It's bad for your reproductive health. And we all see women that have, my next door neighbour, she smokes 40 cigarettes a day and she's got 3 children. That's fine. She might have had a much higher fertility to start with than we have. But generally speaking, nicotine ain't good for your sperm and it ain't good for your eggs. Alcohol. Drink too much, not good for your sperm. Drink too much, not good for your eggs. So if you do drink, make sure it's less than 5 units a week. If you're concentrated, because a lot of alcohol is not good for babies. I don't subscribe to this, I've got to stop alcohol altogether, and I haven't drunk, some patients come to me and say, I haven't drunk for 2 years. I couldn't imagine life without 2 years without alcohol. A bit, but not a lot, not to excess. Allergies. Do you have any particular allergies that may affect your fertility? And also medications. Do you take any prescription medications which can alter your fertility? Chemotherapy, methotrexate, allopurinol, steroids, injectable steroids if you go in the gym. Terrible for your sperm. So these are important things. Now, so once we've taken a history, we then go on to the examination. And it's unusual nowadays, certainly in fertility, that we need to examine a patient. It's not always entirely necessary. But there are certain things we do need to know. Your body mass index. Your body mass index is your weight in kilograms over your height in meters squared. And the ideal fertility, your body mass index should be between 20 and 25. If it's over 30, your fertility goes down. Over 35, it drops like a stone. So your body mass index should be 20 to 25 if you can get it like that. So key, healthy diet, blood pressure, these sort of things. And then we go on to diagnosis, tests. Now, there are 3 tests that you need to have. Okay? Not necessarily before you go to the doctors, but certainly there are 3 tests that any fertility doctor will want you to do, and these answer the following questions. Number 1, have I got eggs in my ovaries? Number 2, are all my bits in the right place? 2 of everything down the side, 1 of everything up the middle. 3, do the sperm that are deposited in my vagina have the ability to swim to my egg? Bearing in mind that for a sperm to swim from the vagina to the egg is the equivalent of a man swimming from Liverpool to New York at 600 miles an hour. They've got to swim a long way. And yeah, I know you're all thinking now, I don't know how anybody gets pregnant ever. Sometimes neither do I. But you can imagine what heat, what smoking can do to those front crawlers, because we want them to be doing front crawl. We want them to be doing backstroke towards the Runcorn Bridge or doggy paddle towards Birkenhead. We want them to be doing front crawl towards New York. Okay? So the test we need as a minimum, a semen analysis. A semen analysis will tell us 3 things: the count, the number of sperm, the motility, the number of sperm that are doing front crawl, and 3, the morphology, what they look like. And believe it or not, we only need 5% of our sperm to be normal. 95% will be dodgy. We only want 5%. We want a good number to be doing 40% to be doing front crawl, and we want 20 million sperm per mil. And that's a normal sperm count. We never can prove whether they work until you've had a baby, but that we would say is normal. Next thing, a scan. A scan to look to make sure that your pelvis is healthy. We want to look for your uterus. We want to look in the endometrium. We want to look in the cavity of the uterus to make sure it's nice and clear. We want to make sure there's nothing down the outsides, and that the ovaries are nice and normal with lots of little antral follicles, little follicles of fluid-filled sacs that may or may not contain an egg. But we want to see them because that gives us an idea of ovarian activity. And then we want to do an AMH, a blood test as a bare minimum an anti-Müllerian hormone. Anti-Müllerian hormone is the hormone that's secreted by the little cells that surround your eggs. It doesn't tell you about the quality of your eggs, it tells you about the quantity. And we want a nice, round, healthy number of eggs. Now, your AMH will go down as you get older, and it goes down to nothing when you're maybe 43, 44. It just depends on how many eggs you were born with. Now, as I said to before, it might be better for you to have a low count, a low AMH and be 20 than a high AMH and be 40. It varies from person to person. So you can't just go onto the internet and say, that's me, I've got an AMH of 3 and I'm 20, I'm finished. Or similarly, I should be okay, I'm 45 and I've got an AMH of 25. It's different for different people, and that's why it's a folly to try and diagnose yourself. And there are lots of self-help sites who will be only too willing to give you well-meaning but misguided information. And my heart sinks sometimes when patients come along and say, I've done my own research and I think this. And you think, where have you done your research? Because you might start going up the wrong avenue and get the wrong advice altogether. And then based on your history, your examination, the tests, we make a diagnosis, whether it's unexplained or male factor infertility or damage to your fallopian tubes or age-related or anovulatory infertility. We can do that based on the history. And one of my old bosses used to say 90% of the time you can make a diagnosis just by talking through the history. And I think to a large extent that gives you an indication as to where we're heading. It's not the tests, it's your story and those 3 basic tests. All the other tests, we can do lots and lots of supplementary tests which may not be useful routinely, but may be useful for individuals. And that's where the skill of the practitioner, the gynecologist, the fertility doctor, the advanced nurse practitioner comes in, because they will have oodles of experience to be able to advise you which tests you may need. What you don't need are tests that are of little value. And this is where evidence-based medicine comes in. So evidence-based medicine is what we try and practice. So when a doctor makes a diagnosis and offers you some treatment based on the diagnosis, you've got to say, what evidence have you got that treatment is going to unequivocally do me good? Is that going to increase my chance of getting pregnant? And there are some that unequivocally will, but there are some that have no evidence, no scientific evidence. They may make you feel better and they may make you feel good, but they might not get you to achieve the pregnancy that you want. So it's important that you segregate things that are definitely going to do you good, that may not do you any good whatsoever, but they may be nice and they may make you feel better. So that's absolutely fine. What you've got to avoid, that the tests that not only not do you any good, but may harm you. And that is not only harmful to your health, but harmful to your pocket, because 50% of you will be heading towards self-funded private clinics because of the lack of facilities on the National Health Service or the restriction in treatment due to COVID. So then you will say, the doctor has said, this is the treatment you need. And then you say, right, what are my chances of getting pregnant? It's all very well a clinic saying, we're the most successful clinic in the world. We did 2 patients last week and 1 got pregnant. So our success rate is 50%. You've got to know, what are the chances for me personally, based on what you know, the history, the examination, the tests, the diagnosis, the treatment. What's my chance of getting pregnant? And then you need to know, how much is it going to cost me? What is the cost of this treatment and my chances? And then you can make the informed decision, whether it's 50%, 30%, or 5%. You know, if your chances, and I've seen patients who say, I've said your chance of getting pregnant is 5%. They'll say, I'll take it. I'll take that chance, because there are, you know, I might be in the 5%. There are some people who say, well, no, you know, I said to a couple, well, within the last 6 months, and I remember this, 30%, and it's going to cost me £7,000. Oh, blow that, I'm going to buy a patio. Oh, that's fine. It's an informed decision. If that's what you want to do, great, because you've made a decision based on information that we have given you. And that, and as long as that information is reliable, then that's, you know, you're in control. So there are other factors as well. You know, am I going to get this treatment privately or on the NHS? And everybody's different. We all know about the postcode lottery, and where you live dictates whether you're going to get the treatment or not. The geography is, you know, I don't want to drive down the motorway for, you know, an hour and a half. I want a clinic that's local to me. Now, care, of course, so we're fortunate. We've got 24 clinics all over the country that are local to somebody. So that's what we want. Am I going to be able, what's the transport like? Can I park my car? Can I park my car for free? Am I going to be walking, you know, half a mile across a rainy car park to get to the entrance of the clinic, and then I get there and nobody knows who I am? Or what's the size of the clinic? You know, and what are the success rates? Now, I'll let you into another secret. It's not where you go for your treatment, it's who you are to a large extent. Of course, there'll be some clinics that are better than us, but in terms of success rates, and there'll be others that are less successful. But the vast majority of clinics, it's who you are. The treatments will be the same. The outcomes will be the same. It's just the delivery. You know, can you trust your doctor or your nurse practitioner? When I pick up the phone, will they answer? Will they know who I am? If I've got a query, no matter how daft it is, will they answer? And these are the sort of things that help you to decide where you're going to have your treatment, or where you're going to have the management, and where you're going to go back to. So they're really important. So I've got a whole load of questions, and hopefully that gives you the basis of what I'm going to answer next. What tests do I need for a minimal consultation? Well, first and foremost, if you have an anxiety about your fertility, you may have had no tests or investigations. Don't worry. Just find a clinic that will speak to you for a start, without having to do a myriad of tests. There are some clinics that want this and that and the other beforehand, but there are other clinics, of which we are an example, where, yeah, well, fine. You know, bring what you've got. If you've had tests in the NHS or privately, bring what you've got. But what we don't want to do is duplicate what you've already done. Or similarly, if you haven't had any tests, we might say, well, you know what, before you come, from listening to your story, you probably get you need one of these tests. But if you haven't, fine, just come along. So, tests you need. Semen analysis, dead important. Nothing happens without sperm. Ultrasound scan and test of your ovarian function. Dependent on your history, Professor Kingsland, I've got a past history of hypothyroidism, we need a thyroid test. Or I've got high prolactin, or my period. You know, there might be other tests that we need to do, but we won't just do them willy-nilly, like the American, you know, hospital programs. Before they've walked, you know, they get out the ambulance, and before they've even got into the casualty department, somebody's ordering an ECG, CTC, and, you know, and you think, well, they haven't even said how old is the patient, what's the complaining of. You know, you've got to find out what's wrong, and then manage your tests accordingly. Male and female fertility assessments. Now, there are some tests that we do in care that may be unique to us. It helps us with our success rates. We want to remain the best to give you the best chances that you can have. So for example, we measure reactive oxidative species. We like to know if the sperm contains free radicals or antioxidants. And these are the breakdown products of sperm that are being manufactured in your testicular factory. There's obviously, when you're having sperm, the old ones are being broken down and new ones are being managed. So you have to make sure that the seminiferous tubules where the sperm's being managed are being produced and kept nice and clean, and the rubbish is swept up by antioxidants, and it's a dynamic equilibrium. Now that might go out of sync, particularly if you take vitamin E just willy-nilly, because that's an antioxidant, and so you might get a disequilibrium of the antioxidants with the reactive oxidative species. So that might create a dysfunction in your sperm. So we want to know not only what the count is, the morphology, the motility. We think that ROS, reactive oxidative species, how well these factories being managed is a good idea. So we'll do that as a routine. So that would be the male assessment. The female assessment, we do a scan, we do an AMH. There are lots of other tests. Again, we've got Care Unity, which looks at particularly with risks of failed implantation or miscarriage, which locates a gene that may be implicated in the male and female that gives rise to miscarriage. But there's no point in doing it if you don't have miscarriages, because it's not prevalent in everybody. But we can do that, and we can actually treat it. The treatment is very simple with blood thinners, something called heparin or clexane. But these are the tests that are over and above, and we obviously we tend to get complex patients, more involved patients, because a lot of us are super specialists in care. So there are some tests that you might need, but be informed, know what the outcome is, what the outcome is for you, and know what the cost is, so that you've got there's no discrepancy about how much it's going to be, and then you don't know what's going. You need to be in control. Okay. Here's a question here. Currently with Liverpool, but referred to Chester for a selective sperm, an SSR, surgical sperm retrieval. We don't really know much about what will follow after this, but we'll be back. Will we go back to Liverpool for treatment? Well, my answer to that is give us a ring, and we'll go through it again. You've probably seen me, so I haven't told you properly. So give us a ring, and I can always get back to you, whoever it is. Lifestyle issues to improve sperm before going on to ICSI, or should we just accept ICSI? It depends. Again, it depends who you are. It's always a good idea to look at your lifestyle. Make sure do a myoxis. Make sure you're taking the right supplements. If you do take supplements, importantly, what's the right diet for you? Your body mass index, don't forget, body mass index for males is just as important. Testicular health, keep your testes cool. All those sort of things. So you need to ask your specialist as to what's right for you. What options should I have for anti-sperm antibodies? Well, anti-sperm antibodies are things that are generated in the testicle which actually attack sperm. Now, I would say years ago we used to give steroids for anti-sperm antibodies. There's a lot of causes of anti-sperm antibodies, but generally speaking, there is IVF is a treatment, because this is the equivalent. Anti-sperm antibodies are like little rucksacks full of bricks on the back of sperm, which prevent them swimming across the Atlantic Ocean. So what you do, knock them off. Dead easy. Our embryologists, our scientific friends can knock them off. So there's lots of treatments, mainly IVF, but there might be an exception. Next steps after a semen analysis, and also a cycle and day 19-20 blood test. Day 19-20 blood test is to see whether you've ovulated, whether you've released an egg. It doesn't tell you what sort of egg you've released, and you should not just say, well, I'm ovulating, therefore I I must be fertile. You need to know what your AMH is as well to give us an idea as to how many you're ovulating, coupled with your age and all those sort of things that I mentioned earlier. So the next step, ultrasound, sperm test, AMH, see a specialist, advanced nurse practitioner or doctor. Advisable to do a test of sperm. Partner has a low count, morphology and motility. We have had 1 cycle of ICSI with 1 embryo. Again, it depends who you are. Always, never underestimate sperm, okay? Get your sperm test, get some advice about that. You haven't told us how old you are, what your body mass index is, what your AMH, because these can all affect the fertilization rate, whether you've had 1 embryo or not. And also, we need to know how the embryo divided, because quite often a problem with the sperm occurs on day 3, 4, and 5 of embryo development, whereas a problem with the egg occurs a little bit earlier. So all these things we can learn about your first cycle of treatment and see why you only got 1 embryo and what we can do about it in the future. So your doctor who's looked after you for that cycle should be able to say, well, this is what we've learned, these were the problems, this is how we're going to fix it to give you a better chance next time. I've had 2 failed FETs, 1 failed, that's a frozen embryo transfer, and 1 failed fresh transfer. Do I need an endometrial receptivity assay? I would say yes, you do. Now, you've had 3 embryo transfers that have been unsuccessful. At this point now, we need to look to see what the problems are. Could there be a problem in the embryo? And we've got something called care maps, which we look at the growth and development of the embryos in the laboratory to see how quickly they're dividing, when they divide. We actually used a closed culture system, so the embryos are videoed, and we take measurements every 10 minutes, and we put all the measurements into an algorithm called care maps, and that predicts which embryos are likely to turn into pregnancies. We can biopsy the embryos as well if we need to, which can tell us, those embryos genetically normal, because only 50% of embryos are genetically normal, and that gets higher as you get older. So when you're 40, 25% of embryos are genetically normal. And you may want to know, is my embryo genetically normal? We can look at it and say it's beautiful and divided well, and that gives us some indication, but it doesn't tell us absolutely incontrovertibly. Similarly, what is the environment we're putting it back into? There's a lot of information coming out now about the endometrial environment, whether the endometrium is at the right stage for the development of the embryo. So are you putting it into a lock and key so that the synchronicity is right? Whether there's evidence of infection that might just be lurking on the undersurface of the endometrium, or indeed what your microbiome is, whether there are a good number of good bacteria where they're supposed to be, and this is where probiotics come in. So that's a very fashionable, it's gaining a lot of scientific credibility. It's not entirely evidence-based, but I think it will become evidence-based, and it's easy to fix if you know the problem. So these are the sort of things you should be thinking about now. Let me just have a look, see if we've got a time for 1 or 2 more. 2 more, I think we've just got time now. 2 more. Single lady, 30, no idea of my fertility, considering the future. Will I freeze my eggs, or will the fertility assessment tell me if I have time? Exactly. I think it's very sensible if you're single, or or you're in a relationship and you're not considering, you want a family, you're not considering just yet because you've got other constraints on your life. What a great idea it is to check your fertility, and if necessary, have an insurance policy. Freeze some of your eggs and save them, because they'll be frozen in time. So when you come back when you're 40 or 45 and you're no longer producing good quality eggs, you can go back to the bank and get your old 30-year-old eggs that are frozen in time and use those. I always find it's a great insurance policy for some people, not everybody, but it's in the same way as we insure our house, our contents, our car, our pets. Why don't you insure your fertility if you want to delay your fertility? Because There's no treatment for time. There is no treatment. We can't turn the clock back. This is an actual way of turning the clock back. And there's so many nowadays. The technology for freezing eggs has improved massively. So it's something to think about. Discuss with your partner, your doctor, your fertility clinic, and then make the best decision that's for you. Can I have more tests with my consultant at my first consultation? Of course you can. It's your consultation. So by taking a history, by doing the examination, by knowing the scan, by knowing your AMH, by these sort of things, then whether you need more tests, yes, you can have this test, you can have that test, this is what it will demonstrate, this is how much it costs, and this will improve your chance of getting pregnant in our hands by this amount. And then once you've got all the information, then you can make the decision which is best for you. And we have, the important thing is for you to be in control of what you're doing, not somebody else. So you must ask the questions. If you say, well, I didn't understand that, that's fine. And a lot of patients will say to me, well, Professor Kingsland, I think this question is going to be a bit daft, but I bet it's not. It's not daft to you, because if you want to ask it, and hopefully you'll get the answer that you want. And it's all about your journey. So at the end of the day, you have done the best for yourself, and we have done the best for you. And if something is not to your satisfaction, ask. We have a central general inquiries and management team that you can always pick up the phone to. They're great, the girls on the desk, Lauren, Shaw, and all the colleagues there. If you've got a doubt and you're a patient of ours, just pick up the phone and ask the question. Similarly, if you're in a clinic like Birmingham, Nottingham, Liverpool, then use our portal. You can email us, you can phone us, and sometimes with the best will in the world, it's difficult to get to the phone straight away, but we'll get back to you, or we'll email you. Gosh, there's loads and loads of questions coming through, but I think we've run out of time. In fact, we've overrun time. So what we'll do is I will ask Chloe to collate these questions and maybe get back to you, and we'll have another session sometime not too distant future. I think we've got one in a fortnight where Amy and I are talking, but I hope that's been useful, and I hope that's formed a little scaffold for you. I'm sorry we can't go into individuals, but individual cases all the time, but I hope that's helpful, and have a good evening. Don't get too cold, and I'll see you again soon. Bye-bye.